Good evening, colleagues. This is Dr. Helarose Ilesterio from Antique, along with Dr. Mitzi Banate from the city of Rojas, Capiz. We will be your moderators for tonight. Being the youngest chapter of the PCCP, it has been a challenge to come up with a webinar worthy of your precious evening. Despite the differences in our schedule, our preoccupation with this pandemic, and several after CME Zoom meetings and briefings from the PCCP National Office with Ma'am Joanne, we are proud to present this rare disease, which is more prevalent in our region, the X-linked Dystonia Parkinsonism or the Lubag Syndrome. We have gathered clinician experts in their own field with experience in managing this rare disease. So now, let us begin the program with an opening remarks from Dr. Eileen Aniceto, Chairman, Committee on Chapters.
Good evening. Good evening, everyone. So again, I'd like to welcome everyone to this new initiative of the PCCP to involve and empower our chapters from all over the country, and so that we can make full use of the effect of the pandemic that we're now going virtual. So even if it's virtual, we're seeing each other. So I think this is the first that topic that one is not about COVID, and two, that it involves multidisciplinary professionals. So I'm really excited to listen to this particular webinar. So thank you for putting together such a renowned team, and I hope that everyone will have as much learning as and excitement as I have for this particular topic. So welcome everyone, and thank you for attending tonight.
Thank you, Dr. Aniceto. So now we will have the welcome remarks from our president of the NorthWest Panay Chapter, Dr. Juliet Macahilas.
Pleasant evening to our PCCP President, Dr. Greg Ocampo, to the Board of the Directors, the Chair, Committee on Chapter, Dr. Eileen Aniceto, Chair on CME Committee, Dr. Lisa Garcia, the different chair of the different committees, the president of the different chapters, our esteemed guest speakers, colleagues, and friends, welcome. So this is the 6th chapter initiated CME webinar. So tonight, the NorthWest Panay Chapter will present or will take a little detour from the usual primary pulmonary topic as mentioned by Dr. Aniceto to a primary neurologic condition which can cause havoc to the respiratory system if not identified or treated early. So this is a rare condition, unique and endemic only in Panay Island. So we are going to have a multidisciplinary approach in demystifying to you this condition. So we have invited distinguished speakers who are experts in their fields from the genetic point of view to the pulmonary, neurology, gastroenterology, and rehab medicine. So on behalf of the PCCP NorthWest Panay Chapter composed of 15 members from Aklan, Antique, and Capiz, I would like to thank you all for joining us tonight. So again, a pleasant evening and happy learning.
So now we go to the lecture proper, but before the lecture proper, we will be showing a video presentation of the Sunshine Foundation, which advocates on finding a cure for X-linked Dystonia Parkinsonism, which you can also find in YouTube. I will be introducing the distinguished speakers for tonight, 5 and all. And after that, please write your questions after their lecture. Please write your questions in our chat box as we go along, so that after the last speaker, Dr. Mitzi Banate will be taking over for the Q&A portion. Okay, so to introduce our speakers for tonight, Joanne. Okay, our first speaker is Dr. Eva Maria C. Cochonco de la Paz, Executive Director of the National Institutes of Health, Clinical Associate Professor, Department of Pediatrics, UP Manila, 1994 up to the present. She's also the training officer of the Section of Clinical Genetics, Department of Pediatrics, UPPGH, from 2002 up to the present. And also she's an Research Associate Professor 7 of National Institutes of Health, University of the Philippines, Manila, from 2004 up to the present. She is also the Assistant Director and Head Cancer Genetics Laboratory, University of the Philippines, Manila, from 2002 up to the present. Okay, for our next speaker, of course, we all know him, our very own Dr. Abundo Valgos. He had his medical degree at the UP College of Medicine, spent his internal medicine residency and pulmonary fellowship at UPPGH. He is a fellow of the PCP as well as the Life Fellow and past president of PCCP. He is now practicing at the Health Centrum Hospital, Rojas City, which is the head. For our next speaker, she's also a native of Rojas City, Capiz, a neurologist, Dr. Rodeline F. Villarreal Jordan. She studied at West Visayas State University College of Medicine, spent her internal residency training at St. Paul's Hospital, Iloilo City, and trained at St. Luke's Medical Center for her adult neurology. She is a fellow of the Philippine College of Physicians. The next speaker is a gastroenterologist, Dr. Omar John B. Mejia, also from Capiz. He is a Doctor of Medicine from the UP Manila College of Medicine graduate, spent his Master's in Management major in Hospital Administration from Philippine Christian University. He's also had his Master's degree in Hospital Ad at UP Manila, and he spent his fellowship in gastroenterology and digestive endoscopy at Manila Doctors Hospital. He is a diplomate and fellow of the Philippine College of Physicians, Philippine Society of Gastroenterology, and Philippine Society of Digestive Endoscopy. Our last speaker, but not the least, of course, is Dr. Michelle B. Almeida, a rehab specialist, also from Rojas City. She is now the head of the Department of Rehab Medicine in Capiz Emmanuel Hospital, the Health Centrum Hospital, all in Rojas City, and the head of the Speed Recovery Physical Medicine and Rehab Medicine Center in Pasay City, Iloilo. She is a true blue Capizena. Okay, so she's the last speaker for tonight, and I will now turn you over to the lecturer proper.
X-linked dystonia Parkinsonism, also known as Lubag Syndrome, is a rare X-linked progressive movement disorder exclusively found in males of Filipino descent, especially from the Panay, Philippines. The first sign of the disease is Parkinsonism, which is a group of movement abnormalities, including tremors, unusually slow movement, rigidity, postural instability, and a shuffling gait that can cause recurrent falls. Sunshine Care Foundation, a beneficiary of the Philippines' top FM station Wish 107.5, advocates on finding a cure for X-linked dystonia Parkinsonism. It is an international non-governmental organization led by a Filipino-American Harvard alumna which currently takes care of 200 XDP patients.
The foundation started as a scientific endeavor to really try to find the cure for this disease, but of course you're helping people. So it had to have this humanitarian aspect.
Attorney Geraldine Acuna Sunshine shares how this rare genetic disease can break a family apart.
And so what happens is the wife ends up having to care for the husband, having to care for the children, having to work a job, and she is very stressed out and stretched thin. And sometimes the stress is so high that she just leaves. Di na niya kaya eh.
Attorney Geraldine is the first Filipina to be part of Harvard University's Board of Overseers. One of her biggest achievements, she says, is the creation of Sunshine Care Foundation for Neurological Care and Research,
where we care for the patients, provide free medical care, socioeconomic help, resilience training in the communities, especially in Capiz and the rest of Region 6.
Sunshine Care Foundation was the recipient of a 100,000 peso grant from top FM station Wish 107.5 during the celebration of its 5th year in August 2019. Attorney Geraldine is grateful for the gift, which will benefit not just the XDP patients under their care, but also their families and communities.
I care about the patient so much because I see my brother in every patient. And to me, it doesn't matter who you are or what you do, what your job was, what your status is in life. We are joined by this disease and we are united by it.
Thank you for inviting me to give a short presentation on the genetics of X-linked Dystonia Parkinsonism and genetic counseling in XDP. In 1976, Dr. Lillian Lee and co-authors published in Advances in Neurology this seminal article on a condition with an unusually high frequency in Panay, Philippines, presenting as torsion dystonia. 23 of the 28 cases, accounting for 82%, are from the island of Panay, and 19 of the 23 are from the province of Capiz. These 28 cases belong to 25 families. Pedigree analysis reveals 6 families with several members affected, all males. 2 families show features suggesting possible sex-linked recessive transmission, a mode of inheritance previously undescribed in literature. They differ from previously described cases in several aspects. Number 1, sex preponderance. All of the cases are male. Number 2, older age of onset, mean age of 31 years old. Number 3, possible sex-linked recessive transmission. And number 4, spasmodic eye blinking was the first symptom in 4 patients. By 1990, the American Journal of Human Genetics published 36 affected males from 21 families, with 12 kindreds having a history of multi-generational dystonia. Only males of maternal ancestry were affected, and in 7 of these families, maternal grandfathers reportedly had dystonia. There was no male-to-male transmission. Several secondary causes of torsion dystonia were excluded, including Wilson disease, aminoacidopathies, as well as organic acidurias. These findings substantiate the existence of an X-linked recessive form of primary torsion dystonia. Understanding the genetic basis of XDP has been a challenge for many years. XDP is thought to be due to an impaired expression of the Tata box binding protein associated factor 1 or TAF1 gene. TAF1 has been mapped to the long arm of chromosome X, but previous studies did not reveal mutations in the coding regions of the gene. Instead, 5 disease-specific single nucleotide changes called DSC1, DSC2, DSC3, DSC10, DSC12, plus a 48 base pair deletion and an SVA retrotransposon insertion have been identified in all affected individuals. Retrotransposons are highly abundant mobile genetic elements that contribute to genome instability by acting as sites for recombinations and rearrangements, by influencing expression of nearby genes, and by causing mutations that disrupt genetic information. Bragg and co-authors in 2017 have further analyzed the sequence of the SVA retrotransposon in the TAF1 gene. This is the X chromosome where the TAF1 gene is located. These are the haplotype variants consisting of the 5 single nucleotide substitutions annotated as DSC1, DSC2, DSC3, DSC10, and DSC12. And this is your 48 base pair deletion plus the SVA type retrotransposon insertion. These are the 8 genes in the region, including TAF1. And this is the relative position of the SVA inserted antisense to TAF1. And here are the hexameric repeat of variable length among affected individuals. They found that with an increase in repeat number, this is strongly correlated with earlier age at disease onset. The authors propose a mechanism of transcriptional interference with the XDP-specific SVA insertion in TAF1. On the left is an illustration of the central dogma, the process of DNA replication and RNA transcription, followed by protein translation. RNA polymerase II is an enzyme that transcribes messenger RNA together with other transcription factors. On your right, you will see that in wild type or normal cells, the RNA polymerase II successfully traverses the intron part of the TAF1 gene, generating a transcript that splices sequences derived from exons. In contrast, what is seen in XDP cells is that the intronic SVA insertion may create multiple barriers to the RNA polymerase II, interfering with the efficient transcription of TAF1. These obstacles may potentially decrease transcription of downstream exons and or alter splicing at these loci. Because we know a bit more about the changes in the genome among affected individuals, we are able to offer DNA testing to confirm the diagnosis. The test detects the presence of the SVA retrotransposon insertion in intron 32 of the TAF1 gene. When this SVA is present, a 3,229 base pair PCR product is seen here as a band, while a normal result shows a smaller 599 base pair PCR product. Female carriers, on the other hand, will have both bands present. the 3,229 base pair PCR product from one of her X chromosomes carrying the mutation, and the 599 base pair PCR product from her normal X chromosome. I will now briefly discuss genetic counseling in XDP. The general population prevalence in the Philippines is estimated to be 0.34 per 100,000. However, the prevalence rate in the Panay group of islands is 5.24 per 100,000. In most cases, there is a history of maternal ancestry from this group of islands, but some individuals have no such traceable ancestry. Approximately 94% of affected individuals have a known family history of the condition. There are no reports to date of any de novo occurrence of XDP-associated variants. This is a typical pedigree seen in families with XDP, demonstrating X-linked inheritance pattern. Several affected males in multiple generations on the maternal side of the family are shown here as black squares. The unaffected males are open squares. Carrier females are the circles with the dots in the middle. Males generally are affected as they have only one X chromosome, as they are XY. A male with XDP passes on the mutation in the TAF1 gene to all his daughters who are carriers, but none to his sons who remain unaffected. Women who are carriers have a 50% chance of transmitting the TAF1 gene mutation in each pregnancy. There is a 50% chance for daughters to be carriers and a 50% chance for sons to be affected. Female carriers are mostly asymptomatic, although a small percentage may manifest symptoms. Global research efforts continue to better understand the underlying biology of this uniquely Filipino disease to find a cure at the soonest time possible. Thank you very much for your attention.
Greetings to the PCCP national officers and members and all the guests and viewers of this webinar. As mentioned by our first speaker, X-linked dystonia Parkinsonism is rare, with a prevalence of 0.31 worldwide, but not so rare in Panay Island with a prevalence of 5.74, specifically in the province of Capiz. And that's why it's called the XDP of Panay Island, or Lubag. Movement disorders, as in Parkinson's disease, produces dystonia, which is complex, highly variable in presentation, and results in different types of movement disorders like chorea, tics, dystonia, and tremors, which will be further explained by our neurologist later. It's classified by onset, by body part involvement, and by the causative factor. Several studies have been done on respiratory function and Parkinson's disease, starting from Vinken in 1984 to the 1994 study of Izquierdo Alonso, the 1996 study of Sabate, the 2000 study of Onodera, and the 2001 study of Herrera, as well as those recent studies of Depandis, Wenner, Satraprabha, and Secombe. I will discuss in more detail certain aspects of these studies with respect to respiratory dysfunction. These are divided into obstructive disease, which is presumed to be probably secondary to direct basal ganglia involvement and axial dystonia, restrictive diseases, which may be due to dysautonomia, myopathy, or because of the muscle rigidity and bradykinesia. And then central ventilatory control, which is probably due to direct brainstem involvement, or the SN-PAG-RTN pathway. And finally, some of the respiratory effects seen may be related to the drugs that are being given to these dystonia patients for the fibrosis, for the dyskinesias, and for the neuroleptic-like malignant syndromes. If you have seen a dystonia patient go through the problems of movement disorders, you will see and imagine how difficult their lives are. They have uncontrolled movements of the tongue, they have uncontrolled movements of all the striated muscles, and eventually they develop disorders in the spine, such as scoliosis and kyphosis. Respiratory dysfunction in Parkinson's disease could be obstructive in nature, and they've seen upper airway obstruction both by spirometry and fiber optic endoscopy, and they've seen the vocal cords fluttering with a frequency similar to the tremors of the hands. There are irregular and jerky movements of the glottic and supraglottic structures, thus leading to intermittent airways closure. There can also be lower airways obstruction. This has been reported by Sabater and co-workers, and even differentiated by these workers, this time correlating with rigidity, resistance to passive mobilization of the cervical column, and cervical spine arthrosis. What about restrictive dysfunction? They have attributed this to dysautonomia and adverse effects referred to the ergot-derived drugs. The myopathic weakness of the chest wall seems unlikely. There seems to be no correlation with tremor or bradykinesia or rigidity. But it has been postulated that the chronic movements that result in disturbances in the spinal column, dorsal spine arthrosis, scoliosis, may be partly responsible for the restrictive function problem. Some authors correlated this with motor features such as gait freezing and falls. So in some, there can be actual effects of skeletal damage due to falls in moderate to severe Parkinson's disease, and correlation with camptocormia and kyphoscoliosis in the advanced stages. What about central ventilatory control dysfunction in Parkinson's disease? It has been postulated that there is some dysfunction of the medullary respiratory centers and consequently of the central drive for breathing. This is involving not only dopaminergic neurons, but also astrocytes. And when astrocytes are lost, this will decrease ATP production, which in turn will result in failure to stimulation of breathing. Degeneration of the dopaminergic neurons may lead to a progressive loss of function along the SN-PAG-RTN pathway. Central breathing dysfunction may explain, at least in part, the abnormal perception of dyspnea. Physiologically, dyspnea is perceived as respiratory muscle effort, but in Parkinson's disease patients, the degree of perception is linked to the strength of the respiratory muscles, so they are having some difficulty in the perception of breathing. Apnea syndrome has been reported in some cases, but reports are few and conflicting. Aspiration pneumonitis or Mendelssohn syndrome, as we all know, is due to parenchymal inflammatory reaction because of gastric contents action or effect on the respiratory airways. On the other hand, aspiration pneumonia occurs when a bacterial infection happens from aspiration of a previously colonized oropharynx or gastric content into the airways. It occurs when the cough mechanism is weak due to chest wall rigidity, dyskinesia, and upper airway dysfunction. In Parkinson's disease patients with dystonia, there are impairments in the control of the epiglottic, laryngeal, and pharyngeal musculature, such that the volitional, oral, reflex pharyngeal phase of swallowing is affected. In fact, they may not be aware about this aspiration that is happening. And you can see from this picture here that this person with dystonia is not even aware that a chunk of chicken is lodged between the throat and the tongue. In the study of Marek and Kaplan in 2003, they found pneumonia in 24 out of the 100 patients that they studied with abnormal cough reflex and swallow function. The incidence of aspiration pneumonia was higher in Korea in Parkinson's disease patients versus those without Parkinson's disease. So what we can do to prevent aspiration pneumonia is try to recognize those patients with dystonia who may have swallowing problems and dysphagia, so that they can be given feeding precautions. It's very important that early recognition is done so that these patients' hospitalization and subsequent aspiration pneumonia is avoided. The usual diagnostic chest X-ray and CT scan after a good history and physical examination with some blood exams should be done, and antibiotic therapy is started based on our guidelines. Pharmacologically, levodopa and other dystonia or Parkinson's disease medications, including botulinum toxin injections, may be given to relax the muscles. And of course, our standard or usual support for oxygenation and ventilation. Some patients with pulmonary TB have been referred to me at the Health Centrum Hospital. And so I was interested on whether or not TB has some correlation or is more common in patients with XDP or Lubag. And so far, I have not found any data on that yet. Interestingly, what I found was that TB is one of the major infectious causes of Parkinson's disease. As early as 1896, Block and Marinescu found a tubercle that damaged the right substantia nigra of a patient with Parkinsonism. And they believe that it was most likely a complication of tuberculosis, and they're actually correct. In fact, many studies show now that meningitis, TB meningitis is a major cause of Parkinson's disease. From a total of 122,000 people with TB in Taiwan versus a control of around 488,000 non-TB patients, they found that there were TB in 1.4 times more in people with Parkinson's disease. Interestingly, studies have shown that drugs that have been used for Parkinson's disease often show anti-tubercular activity, specifically tolcapone and entacapone. And in fact, diseases used for Parkinson's disease are now being studied as possible additional drugs for drug-resistant tuberculosis. So far, what I have presented to you are data for Parkinson's disease and dystonia patients in general. But the question is, are the respiratory dysfunctions in these other movement disorders the same as in XDP? Are the approaches for prevention and treatment the same? And this is the main reason why we are presenting this webinar, to bring to attention to our colleagues the possibility of respiratory dysfunction of patients with movement disorders, as well as in the XDP patient. And this is why we are also planning to do a retrospective study as well as prospective studies on the recognition, diagnosis, prevention of the respiratory dysfunctions, as well as treatment of these disorders in patients with XDP. To summarize, when a patient has a major respiratory dysfunction because of movement disorders, there are weakness in the inspiratory muscle or sometimes rigidity, also expiratory muscle weakness and rigidity, as well as bulbar muscle weakness and rigidity. All of this will result in upper airway dysfunction, cough dysfunction, ventilatory dysfunction, and leading to aspiration pneumonia, diurnal ventilation failure, and even sleep disordered breathing. Thank you for your kind attention and your participation in this webinar. Greetings to
Good afternoon, colleagues. For this afternoon, we will be discussing the X-linked dystonia Parkinsonism. The objectives of this talk will be focused on the demographic profile of patients diagnosed with XDP, identify complications, and discuss medical and surgical management. So for a short review, X-linked recessive inheritance refers to genetic condition associated with mutations in genes on the X chromosome. A male carrying such mutation will be affected because he carries only one chromosome. But for the females, since there are two chromosomes, a female carrying mutation on one gene with a normal gene on the other chromosome will be unaffected but becomes a carrier. So in this figure, if we have an affected male who marries an unaffected female, all their daughters would be a carrier, but their sons would be unaffected. On the other side, if we have an unaffected father who marries an unaffected mother but is a carrier, their daughters, each of their daughters would have a 50% chance to be a carrier, and each of their sons would have a 50% chance each to be affected. Okay? So, X-linked dystonia Parkinsonism is an adult onset, progressive, neurodegenerative, and debilitating movement disorder first described in 1976, affecting mainly male Filipinos whose maternal ancestries originate from the Philippine island of Panay. The XDP usually starts with focal dystonia that eventually generalizes and coexists over time with Parkinsonism. So in the XDP registry, from the paper of Rosales and Lee et al., there are 500 cases from 253 families. For the whole Philippines, we have a prevalence of 0.31 per 100,000. But as we focus on the province of Capiz, this becomes higher. In the island of Panay, there is 5.74 per 100,000 population. But for the province of Capiz, this becomes 23.66% per 100,000 population. In decreasing order, Capiz, Aklan, Iloilo, Antique, and Guimaras. Age of onset would range 12 to 64, but usually starts at 39 to 40 years old. The mean duration of illness is 16 years, and the mean age of death is 55.6 years. In 94% of cases, the initial presentation is dystonia. In descending order of occurrence, most common would be at the lower extremities, 31%. Usually, they would present with toe dorsiflexion, which we call as the striatal toe, foot extension, flexion, toe fanning, knee extension, and flexion. For the craniofacial region, there is jaw opening, closing, deviation, and there is tongue protrusion, rolling, retraction, or blepharospasm. For the neck and shoulder, torticollis, it could be antero, latero, retro, or a combination of the above. And for the upper extremities, there is 14%, and the least would be at the trunk. Regardless of the first site of the regional involvement, initial focal dystonia spreads in 97% and generalizes in 5 years in 84% of cases. On the 2nd to 7th year of illness, dystonic phase predominates. So commonly, you would see torticollis, jaw closing, opening, blepharospasm, but on the 2nd year, there may already be subtle signs of Parkinsonism. On the 7th to 10th year of illness, both dystonia and Parkinsonism coexist. But on the 15th year onwards, you will only see mostly Parkinsonism. So patient would have shuffling gait, mostly rigidity, mask phases, bradykinesia, and so forth. Aside from the motor symptoms, non-motor features are also found in XDP. So in the study of Homura et al., they found out mood and cognition problems. There is relatively low anxiety rate, but the depressive symptoms are as high as 92.9%. Thus, the suicide rate becomes 10%. There are also impairments in the frontal lobe functions of abstract thinking and motor programming. Other concurrent psychopathology were anxiety disorder, social phobia, of course, because there is still a stigma in the community, agoraphobia, and other affective disorder, major depression. 20% of patients were already wheelchair-bound or bedridden. Mean age of death is 55.6 years, and most common would be malnutrition and aspiration pneumonia. Because of the involvement of the oromandibular muscles, there is difficulty in chewing and swallowing of food. So in some patients who are in generalized dystonia and who are bedridden, food is manually pushed down to the throat for them to swallow. In the chart review done by Homura et al., there were 94 deaths in the registry. None of the patients had prior documented psychiatric illness, but 21 of the deaths were attributed to suicide. And 17 of these 21 patients were in the generalized dystonic stage at the time of suicide. Manner of suicide: most common is hanging, followed by refusal to eat. Literally, they starve to death. Few studies are available on the medical management of XDP. Most of them are anecdotal and of personal experiences, some of which are case reports, case series, but there are no published randomized controlled trials. So, there are oral medications which are being used and chemoderivation, the muscle afferent plaque, and the botulinum toxin injection. So these are a few of the medications which are being used: byperidine, baclofen, clonazepam, mostly to control the dystonic movements, clozapine, and levodopa, which are given for Parkinsonism symptoms. The muscle afferent block um, were used before using the lidocaine injection, but these did not last long because of the shortened duration of effect, which is 7.9 days. And of course, there are noted uh, adverse events: dizziness, pain on injection site, bleeding, and erythema. Presently, the most commonly used for chemodenervation is the botulinum toxin injection, and this benefits well those with cervical dystonia, blepharospasm, some dystonic movements of the upper limb, oromandibular dystonia, lingual dystonia, and truncal and axial dystonia. We have patients who are being offered with the deep brain stimulation, and this is a procedure wherein electrodes are implanted on the brain, and these electrodes generate electrical impulses that control brain activity. Stimulation of the brain areas is controlled by a programmable generator that is placed under the skin in the upper chest. There are already 11 published case reports on DBS in XDP, and these were done in Japan, Germany. In our center, the Cardinal Santos Medical Center, there are 11 cases done and 12 cases done at MMC and AHMC. So in summary, we have discussed the demographic profile, the clinical course, motor and the non-motor symptoms, medical as well as the surgical management. Thank you for your kind attention.
Good evening, dear colleagues. I was tasked this evening to talk about the prevention of aspiration pneumonia among patients affected by X-linked dystonia and the advantages of an early PEG tube insertion. I am Dr. Omar Jan Mejia, a practicing gastroenterologist here in Roa City, and thank you, PCCP West Visayas Chapter, for inviting me to speak before you tonight. The general principle should always be that whenever the gastrointestinal tract is functional, it should be the preferred route of feeding our patients. Several studies have shown the benefits of enteral feeding on maintaining intestinal structure and function. It can also aid in the recovery process and reduce the period for convalescence of certain diseases by improving organ function. It has the additional benefit of reduced cost and low risk of serious complications. Enteral feeding refers to food intake via the gastrointestinal tract. Enteral feeding may mean nutrition through the mouth or through a tube that goes directly to the stomach or intestine. It is a valuable treatment modality in the management of both acute and chronic illness, and it can be used in a wide range of disease states. Majority of patients who require nutritional support for around 1 month or less are better off with a nasogastric tube. For patients, however, whose nutritional intake is likely to be qualitatively or quantitatively inadequate for a period exceeding 4 to 6 weeks, a percutaneous endoscopic gastrostomy tube is recommended. The most common indications for a PEG tube is to assist in the delivery of nutrition on the enteral route among patients who have dysphagia or difficulties in swallowing. Patients with neurologic diseases such as stroke, dementia, Parkinson's, and other movement disorders usually top the list of patients who require long-term tube feeding. X-linked dystonia of Panay, as we all know, is a debilitating disease affecting mostly male patients with ancestries that can be traced to Panay Island, particularly in the province of Capiz. 27% of dystonia patients have craniofacial symptoms, which causes involuntary jaw closing and opening, tongue protrusion and retraction, and therefore have problems in swallowing. Because of this, malnutrition is one of the serious complications of the disease that must be addressed. The other is aspiration pneumonia. Malnutrition is a basic health issue that adversely affects the prognosis of the disease and increase the risk of morbidity and mortality. Early detection of malnutrition and initiation of appropriate nutrition plan is very important. Enteral nutrition is used in the treatment of malnutrition where oral intake is not possible or adequate. For this, PEG tube is often prescribed. In a study done in Turkey, published in the Asia Pacific Journal of Clinical Nutrition, anthropometric values were compared and they found a statistically significant increase in weight, mid-upper arm circumference, cuff circumference, and albumin levels, as well as a significant decrease in nutrition risk score in patients before and after PEG tube insertion. Results of the study showed that long-term enteral feeding with PEG is an effective and safe method that provides improvement in nutritional status. Careful patient selection is important when inserting a PEG tube. The following are the known contraindications to doing a PEG. Severe coagulation disorders, as patients are prone to bleeding, hemodynamic instability and sepsis, severe ascites and peritonitis, abdominal wall infections and peritoneal carcinomatosis for obvious reasons. It is important to note that percutaneous endoscopic gastrostomy tube insertion is not an emergency procedure. Patients should first be optimized and the risks and benefits weighed and explained to the patient prior to the procedure. An informed consent is also very important. PEG tube insertion is usually considered a safe procedure. However, complications can occur with a variable rate based on study population. Although there is a low procedure-related mortality in most studies, the mortality rate may increase in patients with underlying comorbidities. Bleeding has been reported, usually from the PEG trap, from gastric artery injury, from mesenteric vein injuries, and rectus sheath hemorrhages. This is why adequate visualization by transillumination is very important prior to doing any puncture. Any intra-abdominal organ, particularly the colon and small intestine, is also at risk of injury during insertion. Necrotizing fasciitis is very rare, but a potentially fatal complication of PEG insertion. This is why sepsis is a contraindication to PEG insertion. Buried bumper syndrome is a condition in which the internal bumper has migrated from inside the stomach into the abdominal wall due to tension. This can cause ischemic necrosis of the abdominal wall, which can be very problematic. Periostoma leakage is a complication more common among debilitated patients, those with history of gastric surgery, and in patients with underlying medical condition that predisposes them to delayed wound healing. One of the common indications to doing tube feeding, yet is also considered one of the major complications of PEG tube, is aspiration pneumonia. It is a serious and potentially fatal complication of PEG tube feeding. As we all know, aspiration is defined as inhalation of both oropharyngeal or gastric contents into the pulmonary tree. Patients with X-linked dystonia who are on PEG tube are therefore doubly at risk. One is secondary to the difficulty in swallowing, and the other from the tube feeding process. Risk of aspiration pneumonia and decreased survival rate are the most frequently cited reasons by healthcare teams for starting tube feeding. However, to date, evidence has clearly proven that tube feeding, be it nasogastric or via gastrostomy, does not prevent aspiration pneumonia. On the contrary, It has been shown that the incidence or risk of aspiration pneumonia may be increased by the use of tube feeding. Therefore, the use of tube feeding only serves as an alternative to deliver nutrition. For patients with X-linked dystonia who are on tube feeding, they are at risk of aspiration pneumonia, primarily due to their problem in swallowing and also from PEG tube feeding as previously mentioned. There are several measures, however, that can help in preventing or reducing the risk of aspiration pneumonia among patients on tube feeding. First is oral hygiene. Oral hygiene has been shown to be one of the important risk factors for aspiration pneumonia. Unfortunately, it is the least considered aspect in hospitalized and institutionalized patients. Do not forget that the oral cavity is a petri dish of microflora, which includes gram-positive, gram-negative, as well as anaerobic organisms. A reduction in salivary flow can also increase the concentration of bacteria in the oral cavity. A systematic review concluded that a good oral healthcare routine consisting of toothbrushing, cleaning of dentures once a day, and professional oral healthcare once a week improve the swallowing reflex and reduce the cough reflex threshold and the risk of aspiration pneumonia. Next are medications. Some medications, particularly diuretics, antipsychotics, and anxiolytics, can reduce salivary flow and increase bacterial flora in the oral cavity. Some of these medications can further lead to impairment of swallowing function due to the effects on the central nervous system, which increases further the risk of aspiration. These medications should be reviewed and avoided if not really necessary. Next is GRV or gastric residual volume. The recommendations from the recent consensus conference statement are to stop enteral feeding if the gastric residual volume is greater than 400 ml, perform careful bedside evaluation for a GRV between 200 and 400 ml, and maintain a GRV less than 100 ml. Gastric residual volume, however, is not a reliable marker for aspiration, and it is better to assess the trend in GRV rather than relying on any single reading. If the GRV is greater than 400 ml, assess the patient for complaints of fullness, abdominal distension, absence of bowel sounds, and nausea and vomiting. The healthcare provider may consider giving the patient a trial of a pro-motility agent such as metoclopramide if gastric emptying seems to be impaired. There was a debate on the use of continuous versus intermittent feeding on the prevention of aspiration, but most clinical studies cannot find any difference in aspiration pneumonia between patients receiving continuous pump feeding and those receiving intermittent feeding. But as a precaution, it is recommended to place the patient about 30 to 45 degrees upright prior to feeding and to stay in this position for about 30 to 45 minutes after feeding. There is, however, a significant reduction in risk of aspiration using pump-assisted feeding versus feeding by gravity, which is the most widely used method. In a study by Edward Chang, results showed that pump-assisted feeding shows improved safety, which is documented in the lower rate of diarrhea, regurgitation, vomiting, and aspiration. A more effective glucose metabolization in pump-assisted feeding was also noted, which leads to better glucose levels. As a result of this prospective study, pump-assisted feeding is recommended for bedridden patients requiring long-term feeding via PEG. The use of elemental feeding. A study published in the American Journal of Gastroenterology looked at the use of elemental diet as a way to reduce risk of aspiration among bedridden patients on PEG tube feeding. Results showed that a number of patients with nutrients aspirated from the trachea and the number of patients with aspiration pneumonia were significantly less among patients fed with elemental diet versus those fed with standard liquid diet. The authors concluded that low lipid containing elemental diets significantly facilitated gastric emptying compared with a standard liquid diet and were associated with a reduced risk of aspiration pneumonia in bedridden PEG patients. For some patients on PEG feeding with significant regurgitation of the stomach contents or ineffective gastric emptying, the following alternatives may be considered. First is to place a feeding tube into the jejunum through the gastrostomy tube. Alternatively also, some individuals who have had a gastrostomy tube placed who present with recurrent vomiting or aspiration may benefit from a jejunostomy tube. PEJ tubes, however, need more nursing care than PEG tubes and may be more difficult to replace if inadvertently dislodged. Another surgical technique known as funduplication may be considered also for patients with excessive regurgitation. In funduplication, the upper stomach is surgically tightened to reduce the risk of reflux from the stomach into the esophagus. This can be done laparoscopically, which can reduce morbidity. A funduplication and gastrostomy tube in appropriately selected patients reduce but does not eliminate the possibility of recurrent aspiration. Lastly, in a person with reflux and impaired gastric motility, a gastrostomy tube to drain the stomach secretions in combination with a feeding jejunostomy tube may be useful technique to limit aspiration. So in summary, for the past 12 minutes, we have discussed the importance of enteral feeding in a functioning GI tract, that PEG tube is usually prescribed when patients' nutritional intake will most likely be inadequate for a period exceeding 4 to 6 weeks, and that for dystonia patients, PEG tube may be beneficial to address both malnutrition and risk of aspiration. However, evidence suggests that PEG tube does not totally prevent aspiration pneumonia, and so the use of feeding tube serves only as an alternative to deliver nutrition. For patients, however, who are on PEG tube, several measures to reduce the risk of aspiration were also discussed. And these are the following: paying attention to oral hygiene, review of some medications, taking note of gastric residual volumes, proper positioning during feeding, pump-assisted enteral nutrition, the use of elemental diet, a feeding tube passed into the jejunum through the gastrostomy tube, a percutaneously placed jejunostomy tube, funduplication, and jejunostomy with concomitant gastrostomy tube. Thank you for your kind attention.
Good evening, everyone. And now, good evening, everyone. And now let's discuss the rehabilitation in dystonia. Again, to re-emphasize the physical presentation of dystonia, let's get back to its definition. It is a neurological movement disorder which affects one or more body parts by involuntary, sustained, or intermittent muscle contractions causing abnormal postures, repetitive movements, tics, or tremors. The rehabilitation for isolated form of dystonia, like cervical or focal hand dystonia, is usually targeted towards affected body parts and focuses on sensory motor control and motor retraining of affected muscles. Recent studies revealed people who live with dystonia experiences a range of functional and non-motor deficits that reduces engagement of daily activities and health-related quality of life, which should be addressed with therapeutic interventions. These findings support the need for a holistic approach to the rehabilitation of dystonia, where assessment and treatment should involve non-motor signs and symptoms and not just the dystonic body part. Cervical dystonia is the most common form of idiopathic isolated dystonia affecting the head and neck, with motor dysfunction and pain causing significant distress and disability. And the most common medical treatment is the regular botulinum toxin injection, though patients experience limited satisfaction. Botulinum toxin injection is maximized when performed in combination with physiotherapy. However, scientific evidence for the efficacy of physiotherapy in dystonia is scarce. Many studies were provided of physiotherapy with or without botulinum toxin injections in small clinical trials with varying results and with varying rehabilitation approaches. However, all these interventions targets primarily the impaired musculature of the neck. Physiotherapy would focus on exercises of the neck to reduce activity in contracted muscles and enhance strength and function of their antagonist muscle. Motor symptoms such as head tremors, abnormal head posture, and jerks are the most observed and burdensome symptoms in dystonia. Also observed are deficits in balance, gait, and function. Non-motor symptoms like pain, fatigue, sleep, and mood disorders limit daily life function and negatively impact quality of life. Thus, the need for more holistic approach to rehabilitation. People living with cervical dystonia have the typical head turn posture. Assessment of physical function, gait, function, and balance should be included. Proprioception, visual feedback, vestibular feedback have vital roles in maintaining the upright position and balance. The physical function is tested by the time up and go test, which measures gait speed, turning, and balance. Time up and go is increased in cervical dystonia due to the aberrant head posture and delay in stepping reaction time. Aberrant head posture with reduced cervical range of motion with the neck inflection may be correlated with delayed simple and choice reaction time and increased postural sway, while limited cervical rotation was associated with slower time up and go completion time. In delay in stepping reaction time, there is reduced step length and increased step time and spend more time in double support, meaning both feet on the ground, with slower walking speed, all of which are consequences of poor balance control. The goal in physiotherapy is to enhance stability during walking, with emphasis on longer time spent in double support and reduced time in single support. Also, postural sway is very important. The longer time spent in double support and reduced time in single support were also associated with a high rhomboid quotient. Rhomboid quotient is a ratio of postural sway between eyes closed and eyes open. In normal adults, they sway more with eyes closed, while those with cervical dystonia, they sway more with eyes open. This rhomboid quotient is correlated with gait kinematics. Postural sway in medial lateral and anterior posterior directions during eyes closed and eyes open were also studied while in tandem stance. They found out that there is greater acceleration in the medial lateral direction and not in anterior posterior directions. and that there is increased postural sway in those with head tremors. And this would be an important finding in differentiating fallers from non-fallers in community-dwelling older adults. Current treatment of cervical dystonia is focused on the cervical region. However, the evidence summarized highlights the value of adding physical function assessment, postural control, and/or stepping reaction exercises along with gait rehabilitation into the therapeutic management of dystonia. Falling may be a consequence of the physical function impairment in dystonia, such as poor sensory motor control, balance, and gait impairment. The fear of falling is high in patients with cervical dystonia, as reported by Hofland and colleagues using the Activity-Specific Balanced Confidence Scale, or ABC, and Barr and co-workers using the Fall Self-Efficacy Scale International, or FESI. Many of the fallers were living with isolated forms of dystonia, such as cervical dystonia, blepharospasm, and focal hand dystonia, and not those dystonia which directly affects the trunk and/or lower limbs. Further study by Boyce et al. Showed that fallers had significantly more fear of falling and poorer balance confidence than those who did not fall, according to the ABC and FESI scales. People with dystonia report less fear of falling and higher balance confidence than people with other progressive neurological diseases like Parkinson's disease and multiple sclerosis, but similar fear of falling and balance confidence to older, healthy people. Falls-related fear should be addressed from a multidisciplinary perspective, and falls prevention in the most appropriate format based on robust physical and psychological assessment should be included in rehabilitation programs. Vision impairment secondary to dystonic postures and its impact on physical function, visual compensation, and oculomotor fatigue, along with potential neurological impairments like spatial neglect, should be considered important components of holistic rehabilitation. Many people living with dystonia experience non-motor symptoms, contributing to disability and reducing participation in activities of daily living, and has negative impact on quality of life. It's like a tip of the iceberg where physical symptoms can be seen and non-motor symptoms are often unseen. People with dystonia experiences these non-motor symptoms like pain, which is a prevalent and debilitating non-motor symptoms. Neuropsychologic factors like depression, anxiety, apathy, fatigue, which is commonly associated with sleep disturbances. Exercise is important to cardiometabolic health, neurologically improves neuroplasticity, provides therapeutic benefits, and relaxation. Movement impairments and non-motor symptoms have implications on the amount of exercise and physical activities that people with dystonia engage in. A survey was done by Cambridge et al. To determine the amount of physical activity and sedentary behavior, where people living with dystonia appeared to achieve minimum recommendations for physical activity by means of incidental activity during transport and domestic activities. On average, people reported spending excess of 8 hours per day in sedentary behavior. Common barriers to engaging in physical activities were personal barriers or physical impairments, financial barriers, and lack of trained exercise specialists. And the most common reported dystonic symptoms includes pain, fatigue, and poor balance after exercise. Thus, many people with dystonia do not exercise as it tends to aggravate a range of dystonic symptoms. However, it was also found out that lower intensity exercise was less aggravating than high intensity exercises. So together with medications, a holistic rehabilitation program should be prescribed to people living with dystonia. Physiotherapy, as discussed, occupational therapy, which can help improve functioning, speech therapy, which can improve pharyngolaryngeal and oromandibular dystonia, psychotherapy, which can improve coping with a chronic disease, and in severe cases, should include caregivers. Sociotherapy, which can help patients claim social benefits and acceptance to the community. In summary, treatment for dystonia offer limited effectiveness and patient satisfaction. To provide holistic rehabilitation treatment, patients should be assessed properly both for motor and non-motor symptoms. Clinical assessment of gait, physical function, and balance, visual impairment should be included. Non-motor symptoms should be screened and evaluated. Tremors, jerks, pain and fatigue, balance and gait, fear of falling, vision issues, poor sleep, anxiety and depression has negative impact on daily life and reduces quality of life. Recognition and rehabilitation of the wider spectrum of dystonic signs and symptoms could be the key to improving treatment outcomes, life participation, and overall quality of life. Thank you, everyone, for listening.
Thank you, everyone, for that, dear speaker, for that informative talk, and also for your insights and enlightening us the in-depth of the different aspects of this rare disease, from the genetic etiology to its neurologic sequelae, pulmonary complications. What are the measures should we undertake, and some initiative in managing this disease? May we request all the 5 distinguished speakers to be present tonight virtually. And for some questions, you may type in your question in the chat box, or just raise the hand icon for questions. For the first question, this is addressed to Dr. Garcia. Has there been identified etiologies and reasons why this X-linked dystonia is common in Panay Islands? This is for Dr. De La Paz.
Okay, thank you. I was waiting for Dr. Garcia to reply. They thought about what is written in literature is that there must have been what we call a founder mutation. A founder mutation happens when there's a genetic alteration that's observed with high frequency in a group that is or was geographically isolated, in which one or more of the ancestors was a carrier of the altered gene. And some people might have read about some articles saying that the genetic alteration happened 50,000 meiotic years ago. So the fact that the people in an island tend to intermarry, the frequency of that altered gene became prominent in that group.
Follow-up question, doctor. How early can we do genetic workup for those with affected members in the family?
That's a very good question. Right now, we do testing for those who have symptoms and who show the phenotype of the combination of X-linked dystonia Parkinsonism, and also there are instances wherein they might present just with dystonia, and then the neurologist may think about it as part of the differential diagnosis. But when we try to screen the patients for a diagnosis of XDP, they would show the symptoms, signs and symptoms of the disease. Second is there's a prominent history of maternal ancestry in the Panay group of islands. Those are the important parts of the medical history as well as the family history that we consider.
Okay, thank you, Doctor. Another question for Dr. Jordan. Do affected individuals have to pass all the stages of the disease, or is it possible for them to just have one presentation even at as they age?
If we follow the clinical course of the disease, usually it would present as mostly of the dystonia, dystonic symptoms, and usually would start one body part. This would be seen on as early as on the second decade of life. But as the disease progresses, the dystonic phase would later disappear, and the Parkinsonism symptoms would then come in. But on the 7th to 10th decade, so both of the symptoms, you would see both of the symptoms. So basically, they would have the same course. First, dystonic movements with all the usually the torticollis, the jaw opening. Then later on, you would only see rigidity, bradykinesia, as usually you'd start at the 5th or 6th decade of life, mostly Parkinsonism.
Okay, thank you, Doctor. With regards to the management, should the deep brain stimulation be done on the XDP patients on early course of the illness, say with mild dystonia, either focal or segmental, or will this kind of management also with the patients with Parkinsonism?
Okay. Initially, the DBS is done in those with Parkinsonism, with patients with Parkinson, but later on they found out that dystonic patients usually have Parkinsonism symptoms. So then when they offered they had a study using the DBS with the Parkinsonism, with the dystonic patients, they have found improvement actually, but this will not happen overnight. So it will, of course, the patient would undergo some programming. Eventually, the symptoms would lessen, or some of the features may disappear, and the medication will still be there, but eventually, number of tablets they take per day may lessen as time goes, and really in some patients, but personally I don't have the video, but in some patients really they have some have significant improvement.
Okay, thank you, Doctor. What is the predictor factor for early onset dystonia versus the late onset dystonia?
Oh, I think Dr. De La Paz, could you?
I think this is addressed to Dr. De La Paz. The predictive factor for the early onset dystonia versus the late onset dystonia.
Well, now in the pathophysiology, they have found the hexameric repeats in the as part of the pathophysiology of disease in the SBA retrotransposon, and they think that the number of repeats correlates with the age of onset.
Okay. For those identified as being carriers, is genetic counseling part of the management?
Oh, definitely, definitely. So the first big thing that we do during the genetic evaluation is to do a family history. We do a lot of pedigrees so that we're able to see the inheritance pattern in the family, whether this is the first reported case or there are other affected male members. As I mentioned in my presentation, de novo mutation has not been documented in patients with XDP. So most likely there is really the disease-causing alleles have been inherited by the affected member.
Okay, thank you, doctor. How about access to genetic counseling at all times? Is it present, or is in the absence of the genetic testing here in the Philippines, will observe signs and symptoms enough to diagnose this kind of rare disease?
Well, for many years, our neurologists, especially the group of Dr. Lillian Lee, and of course, subsequently, every movement disorder specialist or neurologist who go to see the patients in Rojas City, they would be just looking at the combination of dystonia. Dr. Jordan mentioned about it sometimes starting as a focal dystonia, eventually becoming more generalized. And then later on, after a number of years, it will be the manifestation will be mainly Parkinsonism or Parkinson's symptoms. So for a number of years, they just use that plus the family pedigree. But now, as I mentioned, we do offer at the Institute of Human Genetics, National Institutes of Health, a way to do molecular testing to confirm the diagnosis for those suspected to have XDP. So in genetic counseling, sorry, that was the question. Over in Capiz, Rojas City at the Centrum, where the Sunshine Care Foundation holds a clinic, there is we have two genetic counselors there who are Hiligaynon speaking. They are graduates of our Master of Science in Genetic Counseling in UP Manila, and they are in that part of the Philippines, genetic counseling is readily accessible. For other parts of the country, we do have, for patients in PGH, we have our genetics clinic where we are able to do counseling, genetic counseling, but we also have, of course, the private clinics of our geneticists.
Okay, thank you. We have a question for Dr. Valgos. Can you open the camera, sir? One question, since these patients are actually suffering from, mostly of some of them are actually having an aspiration pneumonia, is there a role for the rotating antibiotics to give this to patients with XDP who are actually having an aspiration of pneumonia at all times? Sir, you need to unmute your...
Frankly, I don't really subscribe to using rotating antibiotics if they actually do not manifest with aspiration symptoms. So my approach would be just to treat if there is suspicion of aspiration pneumonia. And the approach is really more towards prevention of aspiration. And in preparation for our webinar, I tried to review some of the charts of XDP patients who were referred to me for aspiration pneumonia. And in the 9 years that I've been here in Rojas City, there have been only around 7 patients with aspiration pneumonia who were referred to me. And these were actually easily treated, and they easily improve. But we had to get the a multidisciplinary approach because we needed a neurologist and a gastroenterologist to co-manage, and some of them were recommended for PEG insertion. And that's actually the reason why our webinar now is really multidisciplinary, because I realized that in caring for these XDP patients, we really need to have a team of experts working together.
Okay, for the follow-up question, sir, is the respiratory dysfunction among XDP enough to cause a primary respiratory failure? And is hypoxemia or hypercarbia a common findings among these patients?
Well, as I mentioned in the lecture, this is why I suggested that we do a more thorough study for these patients, because as I said, I've had only around 7 patients who were admitted under my service, and out of that, two major presentations were tuberculosis and restrictive lung disease. They were either kyphotic or scoliotic, and one patient who had very severe scoliosis really also showed retention of carbon dioxide. So, but it's doing spirometry for these patients is a challenge. And in fact, again, if you remember the studies that I showed you, they were doing mostly video bronchoscopy to look at the movement of the vocal cords and impedance plethysmography, and that's actually a very important thing that we'd like to present to the rest of our colleagues, that when the dystonia is quite severe, it's really very difficult to let a patient do spirometry procedure, and if they're actually already having Parkinsonism, it's also difficult for them to, let's say, sustain a blow. So it's gonna be a challenge. For those 7 patients that I mentioned to you, almost half of them actually had CO2 retention. And but when the infection was treated, the carbon dioxide retention actually decreased. So right now, I think we really need to do more studies on specifically for the XDP patients for us to be able to answer that question.
Okay, thank you, sir. How about the role of pulmonary rehabilitation among patients with XDP? Sir?
So I will just respond briefly, but we actually have medicine specialists with us. So as mentioned, the pathophysiology of respiratory impairment in dystonia and Parkinson's disease in general is actually could be restrictive or obstructive or even central. And there are the published data from the group of Dr. Lillian Lee about involvement of the striata nigra in the brain itself. And therefore, all of the possible ways by which rehabilitation would be done is should be observed. So if it's a restrictive type of disease, then rehabilitation training for muscle strengthening. But if it's an obstructive airway problem, I already actually mentioned to you that they saw that the vocal cords flutter and obstruct, and I'm not sure what type of rehabilitation could be done for that, except for maybe doing botulinum toxin injection to decrease the muscle movements and the muscle tremors. Maybe Dr. Almeida can give additional comments.
Yes, for Dr. Almeida, any additional comments regarding the rehabilitation for patients with XDP?
Yes, I agree with Dr. Bunds. There are no studies yet regarding the pulmonary rehab. Agree with the explanation of Dr. Bunds also. So honestly speaking, we don't have much referrals for pulmonary rehab with in dystonia patients. So for the obstructive um, causes of the respiratory problem, maybe we can offer those of relaxation techniques and then deep breathing exercises, because this dyspnea could um, possibly due also to the desynchronization of the muscle contraction, and could be aggravated also um, by movements. Yeah. So yes, I agree. We need more studies on that.
Okay, thank you. Sir, Dr. Valgos, since the Sunshine Foundation at Health Centrum, and this is actually one of the research arm for this kind of project. So when faced with suspected XDP, who to approach for the registry and who to refer for further evaluation? Do you have any contact numbers or website for inquiry for just some of our colleagues who are actually having encountering this kind of type of patients? Do you have a website for inquiry?
Well, the movement disorder clinic was established here in the Health Centrum Hospital 8 years ago. And for several years, the group of Dr. Lilian Lee and her colleagues, neurologists from UPPGH, Philippine Children's Medical Center, Makati Medical Center would come here once a month. But later on, they actually developed their own team. And I think Dr. Jordan is one of those who are in-house here, who holds a clinic every Friday. And care, Sunshine Care has its own website, I believe. But they can also get in touch with in the Health Centrum Hospital website. Recently, there was a patient with XDP who flew all the way from Cotabato City to Rojas City to get examined and added into the registry. So maybe I should pass on the platform to Dr. Jordan, who may be able to give us more details on how they process patients.
Okay, so okay. For the new patients, we have a clinic at the Health Centrum every Wednesday. So for the new patients who are referred to the clinic, we have the set of staff which may facilitate the enrollment. So after they come to the clinic, they are being examined, and of course, we need the symptoms, of course, then the family, the pedigree. We have to examine that before years before to be included to the foundation. We require a genetic testing, so they should have a positive um, report. But recently, because one is because of the pandemic, then there is a difficulty in facilitating the test, and it will take some time for the result to come back. So recently, we only have for the patient should be present, and the patient presents with this symptomatically with the movements, and of course the pedigree. Then they are assessed by me, and we have Dr. C, and after which, if they all these requirements are seen, then they may already be included in the foundation. So that's all.
Okay, thank you. There's another follow-up question for you for Dr. Valgos. Can prophylactic tracheostomy as pulmonary measures reduce the risk of aspiration and other respiratory problems?
For the XDP itself, remember I told you I've had 7 patients. There was one patient where we had to suggest tracheostomy because of the severe movement of the tongue, and the patient was always drooling with saliva and basically aspirating oral fluids. But as we all know, the tracheostomy does not really actually totally prevent aspiration. It may just improve the way pulmonary toilet could be done. So suctioning could be done and so on. But many studies have shown that even with people on tracheostomy, aspiration could still happen. So I think the real approach really is to decrease the amount of secretions and to decrease the involuntary movements of the tongue and all the striated muscles in the oral cavity. So I personally do not subscribe to suggesting tracheostomy in all of these patients just to prevent aspiration.
Okay, thank you, sir. May we call in Dr. Mejia? There's a question here. What is the nutritional prescription requirement for patients with dystonia, and what is actually the kilocalories per day requirement? As many of these patients are actually suffering from muscle wasting. Please unmute your audio. Unmute your audio. Okay.
Yes. Good evening, everyone. You have to assess individually all patients, assess their nutritional status. There are many nutritional risk assessment tools present, which you can choose from, and you have to assess the individual nutrition status of the patients, and then from there you can prescribe the nutritional or proper caloric requirement of your patient. For severely debilitated patients with severe muscle wasting, then you go for a higher kilocalorie per weight requirement. In some studies with Parkinson's, they usually advocate or recommend higher carbohydrate content more than the protein content for reasons related to drug absorption, usually with the dopamine drugs. Some studies also would recommend more of polyunsaturated fats than the mono saturated fats. But for the nutritional prescription, it's individually tailored for each patient.
Okay. How often do we change the PEG insertion among patients with dystonia?
It really depends on how you take care of your PEG tube. Before we discharge patients, clear instructions should have been given to the caregiver. For as long as the PEG tube is patent, then you can still use it. The indications for changing PEG tube is one, when it is obstructed; two, when it is already really worn out or there already leakage. I've had patients on PEG for about 14, 15 months, the longest, before we changed the tube. But we've had patients also who require change of tube for as short as 6 months. So it really depends on how you or the patient takes care of the peg tube.
Okay, thank you all.
Mitzi,
Yes,
I'd like
yes.
to add to nutritional aspect, no? Because there's been actually a study done on XDP patients here. 50 patients were evaluated by the group of the Sunshine Foundation, and they actually noted that 79% of XDP patients have had significant weight loss from the onset of disease up to the time that they're able to consult at the XDP clinic here in the health centrum. And they tried to supplement the diet with a moringa leaf preparation, adding 480 kilocalories per day to their diet. It seems this was not enough to improve the BMI of these patients. So that means in addition to what they already take, which is approximately around 1,000 calories, adding 480 calories was not enough to increase their weight. So I'm assuming that because of the use of muscles, when they have a lot of movement, their caloric requirement would be higher than 1,500 calories per day based on that study.
Okay, thank you,
Yes,
sir.
Yes, sir. For patients who really have lost weight, you can prescribe as much as 40 to 50 kilocalorie per kilogram to address the malnutrition of the patient. So it would really be higher than 1.5 kilocalories for an average 60 kilo patient.
Would like to thank all the speakers for your valuable time in our CME initiative lecture in a multidisciplinary approach about X-linked dystonia Parkinsonism. So would like also to thank everyone who was present here virtually. The NorthWest Panay Chapter is the new chapter just recently launched, and it's just over a year. This is actually our first CME activity. So for the closing remark, may we call in Dr. Liza Garcia, the chair of the CME of the PCCP, for the closing remark.
Thank you, Dr. Mitzi, for an engrossing conduct of the discussion. Good evening, everyone. Hoping all of you are warm, dry, and safe from the strong thunderstorms and heavy downpours. On behalf of the PCCP, through our dear President, Dr. Greg Ocampo, our officers and board members who are here, Dr. Eileen Aniceto, Dr. Ime Mateo, Dr. Jubert Benedicto, and Jude Giang, let me express my sincere appreciation to our honorable and respectable speakers. Dr. Eva Maria Cotionco de la Paz for amazingly presenting a simplified presentation on the genetics of this complex X-linked dystonia Parkinsonism. Our very own and our very dear, lovable, brilliant, respectable Dr. Abundo Valgos for an extensive discussion on the respiratory dysfunctions in XDP. Dr. Rodeline Jordan for a wonderful discussion on the demographic profile, clinical management and medical management, clinical manifestations and medical management of this movement disorder. Dr. Omar Mejia for a comprehensive discussion on the prevention of aspiration pneumonia. And Dr. Mikay Almeida for a marvelous talk on rehabilitation for XDP patients. My sincere congratulations for a very well organized, multidisciplinary and very holistic forum on an exciting, unique, rare. Congratulations to Northeast Panay Chapter headed by the very dynamic president, Dr. Juliet Macahilas, and of course, all the members. This is indeed very interesting, and this is the first time I learn about this. So if I get a patient with a movement disorder from Panay, I would consider XDP. No, thanks for this forum. It's also heartwarming to know that there is a Sunshine Care Foundation that is very supportive, and your group are very actively partnering with Harvard University on more of the researches about this unique and rare disorder. I would also like to acknowledge and thank our dear past president, Dr. Ivan Villespin, who's here, other past presidents, Dr. Min Banyares, Dr. Lenny Fernandez, Dr. Jeb Sui, who are regularly attending our CME activities. Dr. Sotomayor is always present. Also, other mentors, Dr. Eileen Wang, Dr. Eloisa De Guia, Chona De Vera. Oh, Dr. Mercy Gap is also here. Thanks for attending. And all of you, our dear friends, Dr. Rolin is here, Dr. Babes Ares. No, we are always excited to see you during our CME activities. And let me invite you all and join you to again join us during the next Pulmonary Rehab discussion by the North Mindanao chapter. The final date will be announced. And on September 4 will be by the Northwest Luzon chapter that will be on vaping in COVID times. And for our CME Pharma-initiated activities, let me also invite you for this upcoming Wednesday, the fourth of the series of discussions on severe asthma. That will be 7 o'clock on Wednesday. And then the upcoming UAP and GSK activity. So UAP activity will be on July 26, Monday, 6 p.m. on the facts and not fakes on, I think this is on on antibiotic use. And the one by GSK will be on August 3, 7 to 8 p.m. Treatable traits, addressing the unmet needs in COPD. So see you all again. Keep safe, everyone. Keep dry and safe from these heavy rains and thunderstorms. Good evening. Enjoy your dinner.